Hello, and welcome to the webinar. My name is John Lozier, and I will be acting as moderator for today's webinar, which is entitled Health Reform and Justice-Involved Populations, Opportunities for the Healthcare for the Homeless Community. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration's Office of Special Population Health. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. We have 3 fine presenters today. I'll introduce all 3 of them right now and then turn it over to the first to begin the actual presentation. Our presenters are Barbara DiPietro. Dr. DiPietro is the Director of Policy for the National Healthcare for the Homeless Council, and she serves in the same capacity for the Baltimore Healthcare for the Homeless Project. Our second presenter is Dr. Fred Osher. Dr. Osher oversees the health components of the Council of State Government's Justice Centers initiatives. He also provides technical assistance to state and local governments across the country seeking to improve their response to people involved in the criminal justice system. He has published extensively in the areas of homelessness, community psychiatry, co-occurring mental and addictive disorders, and effective approaches to persons with behavioral disorders within criminal justice settings. Much of his insight comes from his work as a psychiatrist at Healthcare for the Homeless in Baltimore for 15 years, and he continues to see homeless patients at a shelter at his new home in Charleston, South Carolina. Our third presenter is Megan Condon. Megan is the Release Planning Manager for King County Public Health Jail Services at the King County Correctional Facility and the Mei-Ling Regional Justice Center. Ms. Condon has extensive experience working in the human service and criminal justice field as an advocate, clinician, and program manager. We welcome all 3 of you and thank you for presenting on our webinar today, and we'll start with Dr. DiPietro. Barbara?
Thank you, John. So the overview of today's presentation, just want to walk through a little bit of the Medicaid provisions that are outlined in the Affordable Care Act, the demographics of the justice population that we're looking at today. Then Dr. Osher will talk about the activities of the Justice Center, which is an arm of the Council of State Governments. He'll talk about the priorities for the justice community and some resources and recommendations he has for the partnerships that we might pursue in the healthcare for the homeless community. And then Megan will then talk about the release planning program that they have in Seattle and King County. So again, just want to emphasize that we will have time for questions and answers at the end. So obviously, we're all waiting to see what the Supreme Court is going to say. That should be any day now, but one of the fundamental decisions will be on upholding the expansion of Medicaid to most people earning at or below 138% of poverty. So one of the things that's remarkable about this is that, as many of us know, it's not enough just to be poor to get Medicaid. You have to fall into a certain categorical eligibility. So those that are currently eligible, typically children, pregnant women, people who have proven disability, parents of dependent children, and the like. What this new categorical eligibility is that it's basically the non-disabled, non-pregnant adults aged 19 to 64 who are earning at this level, and that for singles it's about $15,000 a year using the 2012 poverty guidelines. And then, of course, if you're a larger family, the threshold gets adjusted for that. It's important to note that the Medicaid expansion is only open to people who are U.S. citizens or legal residents beyond 5 years. So this doesn't cover everyone, but it does get to a pretty good chunk. One of the things that we're seeing is, of course, Medicaid. There's about 60 million people right now that are on Medicaid. And that's about 1 in 5 people nationally. That includes about 10 million children in CHIP as well. When we look at the expansion population, we've got a couple of different estimates. The Congressional Budget Office, or the CBO, has estimated that 16 million people will enroll in the new Medicaid expansion. The new single adults is what they're sometimes called, or childless adults. You'll hear it called a couple of different things. The HHS has looked at a little higher, maybe 18 million. And then a recent analysis that's come out has said that there's a range, right? Because all of the states are really going to be in charge of doing a lot of the outreach and enrollment. So I think that's why it's so important that we're aware of the activities we can be doing in our communities, because this range of who will actually enroll in Medicaid is highly predicated on state activity. So if we don't do a very good job with outreach and enrollment and really reaching people, then the lower end could be that we only get half of what the CBO had estimated. But if we do a great job, then we might actually get a lot more. So somewhere around, and they're thinking 13.5 million people. Either way, that's a significant expansion of Medicaid, and it is significant benefits to the people that the HCH community serves, typically because of the 800,000 patients that HCH served in 2010, 65% were uninsured. And yet 90% are below the poverty line. So we know that this is something that most HCH clients are going to be eligible for. Now, one thing that's important to remember is that the new law doesn't cover everyone, and that in fact that they are estimating that 21 million people will remain uninsured even several years after these provisions, these expansions go into place. And one in particular issue is the Medicaid eligible but unenrolled population. They're anticipating that to be 8 to 10 million people. And so I think that's really where a lot of the thrust of the outreach and enrollment work that lie ahead for us is in reaching those folks, because we want to make sure that everyone who is eligible is enrolled. When we think about the provisions under the law on who's eligible, there are two different places in the law where they refer to incarcerated individuals. One is talking about who's eligible to participate in the state health exchanges. Now, the exchange is really a marketplace, and in many states will include Medicaid, and this is all referencing people who are eligible to purchase insurance in general. And that will include Medicaid, but also the individual and small group plans that will be offered on the exchange. And where they see here is that you're a qualified individual if you are incarcerated but pending the disposition of charges. And that I've highlighted in red, bold, because that's really the piece that we're focused on, is that anyone who is behind the wall but not yet sentenced or convicted remains eligible for being a qualified individual. A second area in the law addresses who's required to have insurance under the individual mandate clause. Now again, we're looking at the Supreme Court. We'll be deciding on the individual mandate, but again, they use the same language with regard to incarcerated individuals. They say that you are required to have health insurance unless you are one of several categories, one of them, of course, being incarcerated individuals, but other than incarceration pending the disposition of charges. So again, really establishing an intent that people who have not yet been convicted of their crimes remain eligible and have a personal responsibility to maintain health care. When we look at the 16 million that are anticipated to come into Medicaid, that's using the CBO figure, the National Institute of Corrections did an analysis showing that a third of those have some prior criminal justice involvement. And while it certainly, for an HCH community is not foreign to us that we have an overlap between us and those folks who come in and out of jails and correctional settings in general, this really gives a thrust for how can we be using our criminal justice environments and our partners in the community to perhaps identify people who will be eligible. And taking a look, too, is that research has shown that the overwhelming majority of people who are entering our jail system currently are uninsured. So I think this is a tremendous opportunity. When we think about the numbers of people, and again, a lot of national goals are being pegged to the numbers of people that can be enrolled in Medicaid, and I know a lot of state goals are being set in this way as well. When we look at the 750,000 or so people who are a daily census in and out of jails and detention centers, we see that 61% of those folks are currently awaiting court action. So those are the folks who are pending disposition of charges. So when we think about our jail population, almost 2/3 are still Medicaid eligible in this scenario. And so over the course of the year, there are almost 13 million arrests with about 9 million individuals that are going through our jails and detention centers. Depending on the size of the jail, you get a lot of turnover each week. And so there may only be a brief opportunity for folks to be to have some intervention. And so I think it's important for us to really tailor our expectations on what do jails and detention centers and prisons, what is their real opportunity, particularly if they have a very short time period with some folks. Now, the larger the jail, the longer, the less turnover you're going to have each week. And then the smaller the jail, the shorter time that each individual will spend detained. And then when you look at the percentage, the overlap of homelessness, 15% of people who are entering our jails have been homeless at some point in the year prior to their arrest. And so again, we know the frustration in the HCH community of, patients are in care and then they disappear for days, weeks, months perhaps, and because they're over in the jail. And we have no way of knowing it. There's no continuity of care. There's often not a way of being able to communicate some really important health information to be able to make sure that our patients are stabilized even when they're going through some obviously very difficult circumstances. Then when we look at prison and prison releases, there were just over 650,000 releases from prison, and then most of those go to some kind of conditional release, parole, probation, something in the community that will be a hook to them, some condition that is put on them. And so again, this is something that we can really look at in terms of our partners in the community, looking at our community corrections. We've got almost 5 million people who are being maintained, most on probation, most of those on active supervision in our communities. And so sometimes this will have implications for being required to attend or receive drug treatment or mental health treatment or some kind of condition that might be health related. And so this is really an opportunity for us to really forge those partnerships or continue to strengthen the connection between good health and perhaps some major goals. There is a tremendous body of information about the healthcare needs of the justice population. And so it goes beyond the scope of this webinar to really delve into a lot of those numbers. And so much of it depends on who was surveyed, how the survey was conducted, where it was, when it was. But overall, I think it's not a stretch for all of us to see that there is certainly a high prevalence of communicable disease that we're seeing in a criminal justice population, particularly HIV, hepatitis, tuberculosis, sexually transmitted infections, and the like. I think it's well documented in the literature the pervasive behavioral health needs. And I think this is really where the Justice Center is doing some incredible work, particularly in the mental health arena, looking at how do we identify and how do we treat and how do we even prevent people from being criminally involved when they have behavioral health conditions. And we certainly know that there's a high rate of co-occurring disorders in this population. It's what brings them to the attention of police and the attention of arrest and so forth. And so I think that's a familiar pattern to many of us. And then, of course, just like the rest of America, the folks that are typically going through the criminal justice system have high rates of chronic illness. So asthma and cardiovascular disease, diabetes, all of the things that plague the general population also then are in this group, but at higher rates. And what's particularly important to remember is that the only group in this country that has a constitutional right to health care is the population that is in the corrections system. And so one of the things that we look at at our state level in particular is our jails, our detention centers, and our state prisons are usually financing that health care at 100% state expense. And so this is a real opportunity if we're getting a Medicaid expansion that's largely federally funded. How can we start looking at some of the cost implications of being able to shift those costs for health care, not only just looking at it from an economic perspective, but then how can we be delivering better quality care, more coordinated care, and perhaps even with the idea that we can avoid some criminal justice involvement through the healthcare delivery system. And so this is one of the things we want to think about in forging the partnerships that we have with our justice community is what are our common goals and how do we approach people and say, hey, this is something that we're working with the same population, how can we work better, how can we exchange data, how can we be a part of this changing healthcare system in the next several years that really doesn't overlook this population. And so emphasizing the common goals that we have. Everyone is interested in increasing community safety. We're all interested in reducing healthcare costs at the macro level, at the systems level, but we're also interested in what that looks like at the individual level. We're interested in people being healthier. Certainly jail administrators are interested in having healthier populations that they're responsible for. We're interested in seeing our clients also achieve better health, possibly even to prevent and end homelessness through better health. How can we then increase the community service capacity? If there are benefits and structures that are now coming up in the community that we're being able to have greater access to health insurance, which then facilitates greater access to health care services, how is it that that community capacity can be maximized in order to perhaps then prevent the kind of particularly behavioral health issues that again sometimes drive this cycle of criminal justice involvement? And then as an extension of that, if we're really strongly focused on really doing the best job that we can, it's possible that we could even see reduced recidivism through the use of a really coordinated, tight, and capable healthcare system. So these are the things that we're focused on, and we're hoping that we can come away from this webinar really with the key points of a lot of these folks will be eligible for healthcare services. How is it that we do best by them? And so with that, I'm going to turn it over to Dr. Osher, who can talk about the work of the Justice Center and his thoughts for where we might go from here.
Well, thank you very much, Barbara, and thanks to the Healthcare for Homeless Council for opportunity to participate in this webinar and also for the rich collaboration that we've shared over the last several years. In particular, I want to thank Dr. DePietro, who's been the author of several of our frequently asked questions, which I'll be referring to in a moment. The Justice Center is a national nonprofit, nonpartisan membership association. We represent all elected state government officials, all three branches of government, and we strive to provide practical, nonpartisan advice informed by the best available evidence. We have three main components to our activities: the National Reentry Resource Center, which focuses on those individuals that are coming back to our communities from jails and prisons. We have the Criminal Justice Mental Health Consensus Project, which in 2002 released a series of recommendations for states to consider to reduce the frequency and the overrepresentation of people with behavioral disorders in our justice settings. And lastly, a Justice Reinvestment Initiative, where we are working directly with states on their invitation to help address their growing jail and prison populations to come up with policy recommendations that use scarce resources more efficiently and improve public safety of our communities. This is a pictorial representation of some of the facts that Barbara presented earlier. And what we have is this massive expansion of individuals in this country which are under correctional supervision, the largest percentage of individuals of any country in the world in that category. We have 1 in 31 adults that are under some form of correctional supervision at this time, 7 million individuals broken down, as you can see, by these components, where we have over 750,000 in jail, a little over 1.5 million in prison, 800,000 on parole, and 4.3 million on probation in our communities. The good news among this is that the state prison population has actually gone down for the first time in 38 years, and we're hoping to see that trend continue as states have assumed large financial responsibility for providing those jail and prison facilities. The criminal justice administrators who we represent have a variety of priorities and missions. First and foremost is their need to maintain safe and secure facilities, segregating those individuals who might be harmful in community settings and ensuring that our communities are safer as a result of that. Also, as Barbara has referred to, there are constitutional protections for individuals within incarcerated settings, our jails and our prisons, the only class of citizens in this country that have constitutional protections to health care. And so it is a mission of jails and prisons to provide a community of standard of care. It is also the case that arrest becomes a public health opportunity where individuals who may not have accessed health care previously, did not know they had conditions that required treatment, are screened, assessed, and provided care at that point in time. It's critical, if we're going to be efficient with our resources, that we work with community providers on the front end in getting information about that individual's health care needs, treatment status, medications into the facilities so continuity of care can be assured, and importantly on reentry so that when they come out, they can land on their feet, they can access the health care that's needed to ensure and promote their stability and return to their lives within our communities. It is no longer the case that the jail and prison is outside, separate from, different than our community institutions. It's a part of our community. And they have increasingly, as administrators, accepted responsibility for recidivism reduction, stopping the revolving door. We still have a circumstance in which over half of the individuals released from these settings return within a couple of years. And so it is important that the jail and the prison be seen as part of a continuum of services, and in this instance, health services for those individuals that come in contact with those systems. I think it's also important that we keep in mind the distinctions between jails and prisons. They create very different environments for individuals. Jails are churning environments where over half of the individuals are released within the first 72 hours. They're holding the pretrial detainees that Barbara alluded to, in addition to sentenced individuals. They are located mostly within communities, so the opportunity for continuity of care is there. Prisons as an alternative, longer stays, a year or greater in most states. The discharge process a little bit more planned. We have a little bit more of a capacity to understand when an individual might be coming out. And so there can be more exchange of information, more connection from the state prison system coming back into your communities. There are challenges for justice-involved persons, many of those you're familiar with, in getting employment, and in this environment it's tough for anyone to get employment, but there are collateral consequences to being convicted of a crime, and they may be unable to apply for certain jobs, not be able to obtain the licenses necessary to do that work, and there are public employment restrictions as well. We know that access to public assistance can be compromised for felony convictions, prohibited from collecting food stamps, WIC, Pell Grants, federal student aid, again, complicating their reintegration into our community. Very important restrictions on housing, although often misunderstood, and the public housing authorities have a lot of discretion in how to set their regulations, and it's a place for advocacy, as all of you know, in ensuring that people get access to the affordable housing options within their communities. And again, difficulties with medical assistance. 85% no insurance or financial resources for health care currently. Recently released inmates are much more likely to use emergency departments for their health care, high cost, not likely to provide the continuity that we'd like. And again, the lapses in the current structure for Medicaid, with people going in and out of that insurance status, is something that makes it difficult for people to access the care that they need. At the Justice Center, it is one of the most frequently asked questions on all of our components. How do people get screened and assessed? How can people get treated within incarcerated settings? What are the connections that are necessary on their release? And as a result of that, we have a series of frequently asked question documents, and I will give you the location of these websites in a moment. In general, for the reentry population, we ask and answer questions such as, why is it important to screen and assess for health and mental health and substance use disorders? The rates of these disorders within incarcerated populations are extremely high. So as an example, within the jail setting, 17% of all admissions meet criteria for a serious mental illness. That's 4 to 5 times higher than rates in the general population. And the gender breakdown around that is significant. So it's about 14.5% of men, but 31% of all women booked in to our jail facilities meet criteria for a serious mental illness. And these prevalence rates for health conditions, both acute and chronic, are in excess of what we see within the general population. We pose questions about health literacy because we know that an educated consumer is more likely to take advantage of the health opportunities that are there, follow through with appointments, follow through with treatment recommendations. It is critical to individuals, particularly in transition periods coming out of jail and prison, that they get access to the care, that they have continuity of medications upon leaving institutions, that they're able to follow up with some of the recommendations and treatment strategies that have been started within or continued within jail and prison settings, and ask questions about criminal justice treatment and answer them as it relates to sharing information because of federal and state privacy laws. We know that there's a lot of confusion around this, but how important it is that we establish information sharing agreements, business associate agreements with qualified service organizations so that continuity of care, the information that has been learned both inside and outside is shared, and we get efficiencies, continuity of care, and better health care outcomes as a result of that. We have, with Dr. DiPietro's help, looked at the implications of health care reform on justice-involved populations, all awaiting the Supreme Court decision to sort of more clearly outline where we are headed. We need to, and these documents were targeted to our correction administration partners. So, knowing what services must be covered under the new Medicaid package, understanding what a state health insurance exchange is and who's eligible to use them, trying to get a handle on whether people in prison and jail are exempt from the mandate to obtain health insurance coverage. Dr. DiPietro covered that in her earlier comments, and talking about what corrections officials can do to facilitate Medicaid enrollment. If 85 to 90% of those individuals don't have health insurance and 3/4 of more will be eligible under the new guidelines, it's really imperative that we identify who those individuals are, get them the documentation that they need, start the application process, direct them to the relevant health care providers within the community. And given the high rates of homelessness among individuals that have been sent to jail and prison, the health care for homeless community has a critical role in this continuity of care mission. We have, and awaiting the Supreme Court decision, another frequently asked question coming out on the implications of health reform for identification, enrollment, and collaboration, and try to provide some guidance to the correction administrators for their role, their opportunity for partnering with health providers on the outside to assure the better health and public safety outcomes can be obtained. With all this in mind, a few thoughts on recommendations for the partnership. And it needs to be a partnership because no one system can attend to the different administrative and clinical and social issues that surround people that are justice involved. But we need to assess the community capacity to provide prevention, treatment, recovery, and integrated services under this benefit package. As Barbara referred to, there may be 6 million people newly enrolled coming out into our system, and are we geared up and developing the capacity to bring them in with insurance to our healthcare provider networks? We want to ensure continuous health insurance coverage so it doesn't get turned on and off in a way that's haphazard and impacts the continuity of care issues we've been referencing. We've got to pay close attention to transitions. This is a critical period when an individual is leaving jail or leaving prison. We know that oftentimes falling through the cracks, many bad outcomes happening in the first few weeks. We're going to hear a bit in King County how they're managing transitions. There are transitions clinics as models that have been developed in San Francisco as one that's associated with reducing recidivism by ensuring people are linked to health care that they need. We have a model that's been provided by the Community-Oriented Correctional Health Services, or COACHES group, starting in Massachusetts, but now with multiple sites around the country, doing in-reach, providing the same providers both inside and outside institutional settings to help bridge this gap and ensure that people get what they need in this transition. It's important that we adapt some of the care management approaches that address the specific needs of justice-involved subset of chronically ill populations, so that there can be a focus on those individuals with behavioral disorders or other chronic medical conditions, or those with HIV and their treatments, to ensure that it's continuous and effective. You know this world better than I. Improving access to affordable and supportive housing is a critical element of these partnerships. All of health, as we all know, is compromised when one does not have an adequate place to live. And then thinking about the information technology opportunities to bridge and merge data systems to evaluate both the public safety and the healthcare outcomes for this justice-involved population. The resources that I recommend to you on this topic are listed on this slide. I would also welcome you to contact me with questions in follow-up. And at this point, I will turn discussion over to Megan.
Hello, my name is Megan Condon, and I'm the Release Planning Manager for the King County Jail. King County is the 14th largest county in the U.S., and we have 39 different municipalities, making it a very complex legal system. In King County, there are 6 city jails and 2 county jails. Our release planning department is through public health and provides health services in the 2 county jails, King County Correctional Facility and the Mailing Justice Center. As a public health entity, our mission is to assess and stabilize serious health problems for the detained population and to focus on a transition from jail. I think that is key to some of our successes, is that we're not a for-profit medical entity, but that we're actually a public health entity providing health services and just as described earlier, providing part of the continuum of care for this population. The context of our delivery system for the 2 facilities is, on average, we have 80 to 100 bookings. Our daily average population has gone down quite a bit this last year. We're averaging around 1,700, whereas a year ago it was around 2,200. Our annual bookings are 40 to 50,000. Also, as described earlier, this is a fast-moving population that needs quick triage and is usually needs intensive. The median length of stay is 72 hours, with the mean being 19 days. The 19 days for persons who are identified as having a mental illness have a longer stay in jail due to the legal system and competency issues. The release planning department is staffed by 5 master-level clinicians. We provide needs assessments, continuity of care, and pre-release services to the inmate patients while they're in custody. Our goal is to link to benefits, community medical, behavioral health, and chemical dependency treatment, housing, social service agencies, and the goal is to increase the likelihood of patient success after release. Our caseloads are 30 to 50 patients depending on acuity, and we focus on people with priority conditions, those being adolescents, chemical dependency abuse issues, emergent chronic medical concerns, HIV positive, frail and elderly, behavioral health, and developmental disabilities and TBI. So if somebody is identified as having priority and or multiple priority conditions is likely to release, then that is who release planning will provide services for. Although we are do not have the resource to provide everyone who is would qualify for our services. King County Jail has been rumored to have the 2nd biggest psych hospital, quote unquote, in Washington. Our psych unit here in the King County Jail has anywhere from 100 people on any given day. So we have anyone with significant acute psych issues will be brought to this facility. So we are definitely serving at any given time some of the highest utilizers in our community that also utilize the ERs and shelters, etc. In the county. This is a quick model of our release planning program. We focus on transition planning, which requires extensive legal systems coordination to identify that release date. Like I said, there's 39 different municipalities, so often a client can have multiple charges from different jurisdictions and be really caught in a very complex legal web with different court systems. And as they get into one court case and miss other court dates, then it just can go on and on. And so identifying that release date takes quite a level of coordinations with attorneys, probation, and CCOs, which is the role of the release planner. In addition to doing the benefits linkage, the benefits is key to access to any services, as we all know. Unfortunately, while we are lucky and fortunate to have a DSHS worker that does come into custody to get people set up with benefits, we need 14 business days to be able to even make a referral. So while many people would qualify to get onto DSHS benefits, with the time constraints and level of coordination it takes, we are not serving as many as the need exists. For example, in the last 14 months, we served 1,200 persons and made 400 referrals to DSHS, although our referral rate would be much higher if we didn't have the time constraints and complexity of referring to benefits. Release planning has been in effect since 2008. We are funded, part of our program is funded under the Criminal Justice Initiative project, which came from the Adult Justice Master Plan with the intention of reducing recidivism. They did an analysis of our first year and our second year, which was to look at people served by release planning 1 year prior to receipt of services and then 1 year post receipt of services, and looking at reduction in recidivism. And these are some of the outcomes for our first and second year. 2008, we served 607 individuals under that funding, and then in 2009, close to 1,100. And our overall results were a 36% reduction in jail bookings for the first and second year combined cohorts, 28% reduction in recidivism for the first year cohort, and 15% reduction in recidivism for the second year cohort, and an overall reduction in 21,000 fewer jail days over the 2 years. This is a graph of our pre and post booking, again for the first year and the second year. I think what is notable in this is 70% of the persons pre-release planning were booked at least one time, and then for our second year, almost 80% were booked at least one time. These folks that we're in service of are usually booked multiple times, and so reduction in recidivism is, release planning is at the same time long-term and it is acute. So people come in, but we usually see them over time because they come in so often, and so it's reducing the recidivism to the point, hopefully, that they don't come back. This next chart is our release planning changes in total charges. What you're looking at is actually two things at the same time. The solid lines are one graph, and the dotted lines are another. So for the solid lines, the top purple line is all charges, misdemeanor felonies, and at the bottom that goes along with that is the green, which is noncompliance and or probation hold violations. The dotted lines, the blue is the felony, and the red is the misdemeanors. So those are kind of two graphs that go together. And as you can see, for folks who received release planning services, their total charges, there's a consistent reduction in those. And the types of charges. That report can be accessed on the King County website. Some of our keys to success, again, that's critical, is that our access to an in-custody DSHS financial and social workers, and that we're able to do direct referral into many community programs from jail. What we have found is that what ends up in the most successful outcome is when the inmate patient can go directly into services and there's a direct handoff, which again, the release planner role is critical because there's so much coordination with the legal entity, bridging with the DSHS worker, bridging with the community worker so that the day of release, they're actually going straight into services with benefits that are turned on. I think one of our also keys of success is having public health provide the health care so that our overall mission is in service of the goal, especially in particular the health care for the homeless. We also have integrated care team meetings all over the county for the highest utilizer that the jail is a part of. We have information sharing ROIs that allow these care team meetings with multiple partners to discuss coordination of care, and so that is something that's successful in our county. In addition, our King County government, there's multiple partnerships, coalitions, and initiatives that support us directly and indirectly. As I mentioned before, the Criminal Justice Initiative programs, there are several programs that are geared towards justice-involved individual with behavioral health needs to get them direct services coming out of custody. We partner with the Healthcare for the Homeless Network, so there's many network providers that release planning does direct referrals with and coordinates with. Our regional support network providers provide our mental health services in addition to our CD providers that, again, we're able to do direct referral into inpatient chemical dependency, for example. We have a client care coordination that is pretty remarkable in providing permanent supportive housing, which this population needs desperately. And some of the things that fund all this, I wanted to put as examples, is the Mental Illness and Drug Dependency Action Plan and the Veterans and Human Service Levy. These are different things the county has done, taxes that were done to help fund some of these projects. And again, these are just a few examples of our King government at work doing partnerships and coalitions to really fully encompass and to make possible what it takes to do continuity of care out of for a criminal justice involved person. Some of our barriers that continue are not having enough access to services and housing, and in particular the time constraints in getting somebody on benefits. And so this is King County release planning in a nutshell. And with that, I will sign off. Thank you.
Thank you very much, Megan. That's incredible, wonderful information about reductions in recidivism due to the interventions that you're involved with. We now turn to our question and answer period. And the first one is directed to you, Megan, and to Barbara as well. What can you tell us about Medicaid actually paying for services that are now or will be, Barbara, delivered in the jails to Medicaid enrollees? Surely there's some Medicaid enrollees now. Is public health, Megan, billing Medicaid? Do you know?
For in custody?
For services provided in custody, yes.
No. Medicaid does not cover health care for in custody. Medicaid is turned off when people are incarcerated, which creates a huge barrier as people lose their benefits coming in and leave unless we're able to get them started, have to restart the process again once they are leave custody, and then they don't have access to services.
Right. And Barbara, will that be the case after implementation of the ACA?
Well, I think that there are some decisions that the local detention centers and jails can make in deciding to be a credentialed Medicaid provider. Medicaid will only reimburse people who are credentialed through their system, and so I think that this will be a location-by-location specific decision. It may be that, yes, that Medicaid will be reimbursing for those who are eligible for services to their credentialed providers within the correction system. But it may be that they just won't want to fool with it. There's a lot that goes into Medicaid with billing and credentialing and keeping track of things that it may be that they just don't want to do. So that, again, would be at the discretion of the location, and particularly would, I think, to be dependent on how large their population was. If you have a significant population that you could see being Medicaid eligible, then it might be worth the trouble to actually do that. If it's a smaller jail, then it probably is not worth it, but instead maybe to partner more strongly with your community, which of course is recommended anyway, but just in terms of that reimbursement piece.
I wanted, this is Fred Osher, just comment on a couple pieces of this question. One, there is an important distinction that we want to make in our communities for those folks that currently have Medicaid between suspending those benefits and terminating them, and that there has been a lot of different communications about this, but recent clarification allows us to understand that if an individual is not in custody, incarcerated for 12 consecutive months, then the state does have the opportunity to suspend rather than terminate. And various states have taken this up over the last several years. I'd encourage the listeners to understand what their own policies are within their current state, but it's a lot easier to turn on a suspended set of benefits than to reapply after benefits have been terminated. So for jail populations, that is a mechanism that should be explored. And then related to the provision on payment of services, I certainly agree with Megan about the vast majority of services are not reimbursed through Medicaid, yet when services can't be provided within the jail or prison facility, specialty services, surgical procedures, the individual can be sent to community health centers, hospitals, and at that point payment is allowed for those services occurring outside of the incarcerated settings.
Thank you. That's very helpful clarification. Are there, question perhaps for you, Fred, are there regulations requiring prison and jail operators to enroll people in Medicaid or to initiate Medicaid enrollments prior to discharge? And a subset of that question is, can states require their for-profit contractors who are operating jails and prisons to work on those enrollment issues?
Mm-hmm. The majority of care in jails and prisons is provided through contractual services to for-profit corporations, and that the contracting process itself is a fluid one, so that one could put whatever requirements they thought were appropriate and funded within that contract. Is it a mandate? Is it required? Most contracts do require attention to discharge planning. Often it's not with the specificity that the questioner is proposing, but I think it's a terrific idea. We do know that the social workers and social service arms within jails and prisons are often overwhelmed by the numbers of and volume of individuals that are leaving, and sometimes those transition and transition planning services don't get the attention they need. But I like the spirit of the question, and I think it's important that we look at the contracts themselves to assure that there is support for linking people to eligible income supports and entitlements.
And there is a related question about affordable care organizations, those entities that theoretically will be assuring continuity of care among providers. Are there opportunities for prisons and jails to participate, and their contracting service providers to participate in those ACOs as they develop, and is anything being done to encourage that?
going to defer to Barbara on this.
I would imagine that they would be part of a catchment area that an ACO would be defining. But I think how one shares financial risk and makes some of those contractual arrangements around responsibilities for a patient group, I think would probably be pretty complicated if you add in the correctional setting. So it might be too early to tell. And I'd be curious to see, or if any of our listeners are involved or have an area that's looking at that, please let us know, because I think there's potential for that to be really innovative.
Thank you. We have a related question from a listener who asks, is there a notable difference on health care services and availability offered to prisoners in public state-run prisons as opposed to privatized prisons?
I'll take a start at this. I'm not aware of any systematic review of quality of care and distinctions between private and publicly run facilities. The same constitutional protections are afforded within private facilities as those that are sponsored by the state and run by the state government. And so there should be the same standards of care. I don't know, though, of any particular set of studies that have looked at distinctions or differences between the two funding mechanisms for prison care.
Thank you. Just a couple of more questions. One turns from for-profit to not-for-profit. James asks, what opportunities are there for nonprofit entities to provide health literacy education, which was mentioned in that first presentation, I believe, Barbara?
I would say that health centers certainly are ideally positioned to do health literacy, health education as part of their health center mission. Going beyond that, though, I think that you do have issues with the extent to which those services are reimbursed. And I think that that's something that the entire system is struggling with, particularly as we try to do chronic disease management, care management, and such. So in both either non or for-profit, I don't see the reimbursement or the funding mechanism for that yet established. So I think it is a little bit more difficult. Fred, do you or Megan, do you have anything to add to that?
I would not. I think you're accurate in terms of the current environment for funding. I do know, and Megan probably can speak to this better than I, that it sometimes feels daunting to gain access to individuals that are in jails or prisons, and that obviously the safety mission can't be compromised, yet it's increasingly clear that the goals, objectives of both correction administrators and our public health providers line up around the need for good health education and service provision. And so while historically barriers have been seemingly insurmountable, increasingly these days arrangements have facilitated access in reach as possible, and it really is important to start a dialogue between these partners to figure out what mechanisms are available and how to make sure that access is as easy as possible. Megan, you want to share your experience with getting into and being a part of serving within incarcerated settings?
I can speak to here in King County that we have programs that come in to offer this type of education. For example, our public health TB clinic comes in and does, not TB, but the Hep C comes in and does classes, for example, and then we have our public health moms for the pregnant moms. So in this facility, we have a great relationship with DAJD and programs to bring people in to do that type of health education, although it's so individualized per facility and size, and it really is that collaboration with the justice part and having with the programs part.
Great, thank you. I just lost my network connectivity, so cannot read a substantial question that we have from from Mickey, a final question for this webinar. Her question has to do with traumatic brain injury and the extraordinarily high rates that of reported TBI that that the CDC reports. The question had to do with what is being, one, why haven't we discussed TBI already in this webinar, and two, what is being done or can be done to screen for traumatic brain injury and to assure that TBI competent, TBI informed clinicians are available to serve people in prisons. Perhaps we should start with the screening question and direct that to Megan.
In King County, that is one of our priority conditions is the TBI, and Washington State recently passed some legislation around not a requirement, but an encouragement that jails do screen for this here in Washington. I don't know what's happening in the rest of the country, but I think it is an issue that is very critical to persons coming back into custody due to the issues that go along with TBI, and something that is could be looked at more closely and screening looked at more closely as it does impact the criminal justice picture for many individuals. But it is something that we do prioritize here in release planning, at least in King County.
That's heartening in itself. Thank you, Megan. We are approaching the end time for this webinar. Any closing thoughts, items you wanted to get in from the three presenters?
This is Barbara. I'd like to just to make a final takeaway point. Is in all of the suggestions that we've made for the partnerships that are possible or the common goals that are shared between the HCH community and the criminal justice community, really just reaching out and making sure that you've got a good relationship with your jail administrators, your prison administrators, detention center administrators, and ask them and to be active in the health reform implementation process at your state level. I think there's a lot that can be gained from having their perspectives at the table, particularly around the healthcare needs of the inmates that they're required to provide healthcare for, the costs that has, and really having that perspective be educational and informative for that decision-making process.
Great. Thank you, Barbara. And thanks to all of you for joining our webinar on health reform and justice-involved populations produced by the National Healthcare for the Homeless Council. The webinar will be archived on our website at www.nhchc.org within 72 hours. The PowerPoints that we presented, that we worked from today, will be posted there. We shot past the links to the frequently asked questions on the CSG website that Fred referred to, but you can find those at www.justicecenter.csg, that's Council of State Governments, justicecenter.csg.org. And we'll post a link to that as well with this webinar on our website. Please visit the National Healthcare for the Homeless Council website for a listing of all our upcoming and archived webinars and much other educational content that you can access there. The meeting will now be closed. Thank you very much for participating.